Hey, MedSurg students. This presentation of nursing care for cancer patients covers two course outcomes. The first one is to relate appropriate diagnostics and pharmacological therapies to specific disease processes. So we will be talking a lot about diagnostics because early screening is paramount in cancer care because you want to catch it early. And we'll also talk about pharmacological therapies. I don't go deep into that because I know you are taking pharmacology this semester. So we just touch on it, okay? And then the other course outcome that it meets is contribute to the development and implementation of health promotion activities. Very important to prevent cancer and take good care of yourself. And then appropriate to the situation for the med-surg, developmental level, their learning needs and language preference, spiritual beliefs, and culture. So in other words, health promotion and disease prevention is going to involve patient teaching, okay? And we have to make sure it's at the correct level. Okay, so cancer in a nutshell is a neoplastic disease process. In other words, neo means new, plasticity refers to cells differentiating into abnormal cells. Okay, and it could be due to exposure to different kind of environmental factors that we'll be talking about in this video. It also occurs in aging cells. As our cells age, they die. And some cells, instead of dying, differentiate into different kind of malignant cells. Cancer is always going to be named based on the origin cell. So for example, colon cancer. If the cancer developed in the colon, it's going to be called colon cancer. It may invade other tissues because of the proximity, which means the closeness of the organ. So, or it could invade other tissues and organs through lymphatic and blood flow. And once the cancer spreads, we call that metastasis. So just to give you an example, somebody with colon cancer who had liver metastasis, so in other words, the colon cancer spread to the liver, which is quite common, you would say the patient has colon cancer with mets to the liver. And if you look at this picture here, I want to point out that tumors can be benign. The difference between benign and malignant tumors is that malignant tumors do not have a fibrous capsule surrounding them. So in other words, the malignant cells can migrate, and I talked about that. Whereas a benign tumor doesn't spread because it's encapsulated in this tight fibrous capsule. However, it can still wreak havoc. Like I've taken care of patients with brain tumors that were benign, but because of where they were in the brain and they were growing, they could press on the respiratory center or press on the frontal lobe, and the patient would have cognitive problems. So you could still have problems with benign tumors, but less common than malignant tumors. Health promotion and disease prevention is super important when we're talking about cancer and most diseases, right? So just like any other disease, like cardiac disease, you want your patient to eat healthy and exercise. So a low-fat diet with plenty of fruits and vegetables is always a good one to recommend. Exercising 150 minutes at least per week. Limit sugar, salt, nitrates. Nitrates are like processed meats like salami. I love salami. Processed red meat. So you want to tell patients to limit these types of foods. You want everybody to avoid tobacco, and that doesn't mean just smoking tobacco. It also means dip, chewing tobacco, any kind of tobacco product. Limit alcohol. So for women, one drink per day is recommended, and for men, 2 drinks per day is recommended. But really, no drinks per day is really good. Just 2 drinks per day is going to impede your immune function. And I think I mentioned that in the medical surgical care of surgical clients. And then you want to protect skin and eyes from UVA and UVB sun exposure. Now, the UVA penetrates deep under the skin and causes aging. And I remember that because it has an A on the end of it. UVB is the sun exposure, the rays that cause sunburn. And I remember that because there's a B on the end of it. Absolutely no using tanning beds. That's just as dangerous. There was a huge trend a while ago of people getting spray tans, which is good. It's better than tanning beds. But I haven't seen like a lot of people with that orange color around lately, so I don't know if that's died down. But definitely no tanning beds. It's not better. You also want to teach patients to avoid risky behavior, and I'll tell you what I mean about that. So risky behavior would be having unprotected sex with multiple partners. HPV, which you can get from sexual contact, and hepatitis B or C, which you can get from sexual activity or sharing needles. Um, HPV can lead to cervical cancer, and Hep B and C can lead to cirrhosis, but of the liver, and also liver cancer. So you want to tell patients to avoid risky behavior. You want to remove moles as soon as possible. Avoid radiation, like you don't want to be 6 feet from an X-ray, let's say. You want to get the immunizations for Hep B and HPV. And chemoprevention, this refers to taking medication to prevent cancer. Like, for example, ASA is the abbreviation for aspirin. And this is taken to prevent colon cancer. And how I remember that is the colon enters its contents into the anal canal. So A for aspirin, A for anal canal. And then vitamin D is taken to prevent against breast cancer. And how I remember that is I just remember double D's to prevent breast cancer. When you collect data, you're looking for risk factors like advanced age. Um, the older you are, the more prone you're going to be to developing cancer. Women over 50 are at high risk for developing breast cancer, especially if they've never had children. People that are immunosuppressed, and this would be people that are taking immunosuppression drugs for conditions such as lupus, or maybe they've had a transplant in the past. So they would need um, screening for cancer. Chronic irritation, for example, there's something called Bartlett's esophagus, which it results in GERD. Okay, so that and a chronic condition can lead to esophageal and stomach cancer. And then skin irritation, for example, like somebody who has a history of burns could develop skin cancer. Also, we talked about exposure to the sun. Also, that includes tanning beds, radiation. So patients shouldn't be exposed to radiation unnecessarily. And that's why we're so cautious about who actually needs an X-ray, right? Chemicals, like people that work on farms, hairdressers, anybody like nail techs, anybody that works with chemicals, they could be at risk. People that use tobacco. Tobacco is a high risk, and it doesn't have to be smoked. It can be chewed, and it also is a promoter, like tobacco and alcohol together are high risk. I talked about alcohol, 1 drink for women per day and 2 drinks for men per day is the recommendation. But just 2 drinks of alcohol a day can decrease your immune system, which puts you at high risk for cancer. Anybody that eats a low fiber, high fat diet is at risk. And then people with sexually transmitted infections. And I talked about that in one of the previous slides. I talked about hepatitis B and C resulting in liver cancer. So you want to prevent that with immunizations and encourage patients not to engage in risky behavior. The Epstein-Barr virus, which can result in lymphoma. HPV, I talked about that, can cause cervical cancer. We're going to be talking about HIV in a few weeks, and this can patients with HIV can develop Kaposi sarcoma and lymphoma. And then I talked about H. pylori when I talked about GERD. It can result in esophageal and stomach cancer. There are blood tests that act as cancer markers. For example, a blood test for CA. CA is short for cancer, so we use that a lot as an abbreviation. 125 for ovarian cancer. Now, when I worked in pre-admission teaching and testing, We used to do a CA 125 before the hysterectomy, and then again it was done after so the provider could see if the numbers went down. Now the CEA, this is for GI, pancreatic, and colon cancer. So the same thing. We would get a CEA before somebody had a colectomy if they had colon cancer. And then it would be checked after the surgery to see if the value has gone down. PSA, this is prostatic specific antigen, and it's to detect prostate cancer. Now, two things you need to know. Patients cannot have sex. They can't ejaculate within 48 hours of the test because it can result in increased results. And they can't have had a recent UTI infection. Malnutrition is a complication of cancer. Usually, some things that do happen, some cancers are reproducing cells so quickly, it increases the metabolism, and patients can therefore present with extreme weight loss. They could look what's called cachectic. Cachectic means somebody that's very thin, okay? They could have impaired absorption, like if they have cancer in their GI tract. They could have it anorexia due to the cancer treatment, like chemotherapy or radiation treatment. They can get like sore mouths, okay? I'm going to talk about that later, but that could lead to malnutrition as well. So for your nursing actions, anybody that you suspect has malnutrition or looks like they may be developing malnutrition, you want to encourage oral hygiene. You want them to rinse their mouth with saline solution at room temperature before they eat and after they eat. You want to limit liquids during meals because you want the food to take up space in their stomach, so to speak. Like you don't want them to get too full on just liquids, okay? You're going to collaborate with dietary services. You're going to give antiemetics and antacids as prescribed. And there's some lab values you're going to monitor, and this is super important. You're going to monitor for prealbumin. Prealbumin lets you know what the patient's nutrition was like in the last 3 days. It's the most specific lab you can do for malnutrition. Now, the next lab that is good is the albumin. The albumin tells you like maybe a month, like how the nutrition's been in the past month. And then ferritin refers to like their iron sources, because if they're not eating, they're probably going to become anemic as well. Patients with cancer can develop constipation, whether it's from their chemotherapeutic agents or because they lack energy and they're not as active as they used to be. Could be a number of reasons that they have constipation, but the interventions are always the same for constipation. You want to encourage high fiber diet and fluids. You want to put patients, you always try that first, right? And then put them on a stool softener, a laxative PRN. We don't want people to get in the habit of taking laxatives, but if they need one, then you can give it PRN. And then we always want to get the bowels moving with increased activity. You know, try to get them to ambulate to take care of constipation. There are several oncological emergencies and you need to learn how to recognize them. Next semester, I'm going to go into a little bit more depth in SIADH. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. Okay? So tumors can mimic the production of ADH in the body. Chemotherapeutic agents may also mimic ADH. So if your patient develops this, they're going to be soaked inside. In other words, they're not going to have a high urine output due to the antidiuretic hormone. Then inside the blood vessels, there's going to be hemodilution of sodium. So the patient is going to have a low sodium level. Okay, to treat this, they'll be put on fluid restriction. If they're able to eat, you will liberalize salt in the diet if it's not contraindicated, and they will be put on diuretics. Okay, now there are some side effects of having a low sodium and some pretty dangerous ones. So with low sodium, the level of consciousness is going to change. It's going to be altered. Okay, so that means a change in the level of consciousness could indicate SIADH. The muscles are going to be weak because the muscles need sodium to contract. They could develop seizures, which can be very dangerous. That's what I worry about the most with patients with low sodium levels. Because they're soaked inside, the brain is going to be soaked, right? So the brain can swell and they can get increased intracranial pressure. Another reason they have altered level of consciousness. The urine specific gravity is going to be high. So it's going to be greater than 1.030. And then they can have diarrhea and more bowel sounds because low sodium increases the way the bowels work or increases the work of the bowel, put it that way. The next oncological emergency I'm going to present is hypercalcemia. Now, I know you learned about hypercalcemia last semester in fundamentals. I just want you to know an easy way to remember how to recognize the cues of hypercalcemia is that calcium acts like a sedative in the body. Okay? Now, I remember the signs and symptoms of hypercalcemia from the saying, bones, moans, stones, thrones, and psychiatric overtones, okay? So with bones, both hyper and hypocalcemia can cause pathological fractures and also bone pain. So if somebody comes in with a pathological fracture, that's one of the first things I think about. Now, pathological fracture means like they didn't break their leg, so to speak, in like an accident. They had bone pain and it was discovered they had a fracture and they don't know how they got it, okay? So bones stands for bone pain. Moans stands for constipation. Remember, calcium slows things down, so it's going to slow the bowel down. The bowel gets slowed down, they're going to have anorexia, okay? Stones stands for kidney stones. With all that extra calcium floating around in the body can produce more kidney stones. And then throne stands for the one thing that does increase in production is urine output with hypercalcemia because it touches the kidney in such a way that it increases the urine output. Psychiatric overtones indicates, remember, calcium slows everything down so the patient can have depression. They can have apathy. They're not going to be themselves, okay? So the treatment is to deliver fluids and furosemide, which is also a diuretic, and I'll let Miss G explain that to you. I just want you to know that the signs and symptoms you need to recognize, and we're going to give a good flushing fluid to flush that calcium out, okay? Okay, the next oncological emergency I'm going to talk about is tumor lysis syndrome. Now, actually, tumor lysis syndrome is actually a good thing, but we have to prevent what happens in tumor lysis syndrome because the patient could die from it. Okay, so what do I mean by it's a good thing? Okay, tumor lysis syndrome happens after chemotherapy is delivered to fast-growing tumors. And it's just like what it says, the tumor cells start lysing. Okay, so that's a good thing. That's what we want to happen with chemotherapy. Usually day 3 to 5 after the chemotherapy is started. The problem with that is when the tumors lyse, the tumor cells lyse, lyse means break apart. So the potassium, phosphorus, and uric acid is leaked from the cell. So your patient is going to have a high potassium, which can kill them because they could develop dysrhythmias and asystole, which means the heart can stop. They can also develop kidney disease from the uric acid that's leaking from the cells. And phosphorus, a high phosphorus level is going to cause low calcium levels. Okay, so we want to prevent this by administering fluids, and there's medications, and you haven't learned them yet, so I'm just going to tell you simply. There's medications to lower the potassium, the uric acid, and the phosphate, but you need to be able to identify this to prevent these complications from the increase in potassium, phosphorus, and uric acid and the low calcium levels. The next oncological emergency I'm going to talk about is SVC syndrome. SVC stands for superior vena cava, which is a huge vein. It's one of the great veins, okay? And the superior vena cava drains the blood from the head, neck, and upper extremities into the heart. Okay? So what can happen if somebody has SBC syndrome? Now, this usually occurs because there is a cancer in the chest area, like lung cancer or maybe a lymphoma, and a tumor grows, and it presses on the SBC. And because it presses on the SBC, the patient develops all these spidery-like veins, okay, because the body's amazing, and the body makes these collateral vessels. Now, the other thing that happens, because the blood can't get back to the heart, the patient may have like a reddish complexion or a cyanotic appearance of their skin. What you're going to see first is you will see edematous head and neck, and they'll have periorbital edema. That's usually one of the first signs, because the skin under your eyes is really weak. So if you're going to get edema, you're going to get it under your eyes first, okay? So you'll see swelling of the upper arms and torso as well. Now, why it's important you recognize this right away is that this can interfere with breathing. Specifically, the neck and orthopharyngeal area is going to become edematous, okay? So your patient may have trouble breathing. First thing you do when somebody has trouble breathing is place them in high collars. Get that head of the bed up. You're going to remove jewelry and tight clothing. Now, the patient is going to need radiation treatments, which in this case would be teletherapy. And towards the end of the lecture, I'm going to tell you the difference between teletherapy and brachytherapy. They'll be given steroids, diuretics, and they may need a stent placement. So remember, if they're going to have an invasive procedure, you do need to make sure you witness the informed consent and that it's on the chart. Okay, spinal cord compression it's really important that you are able to recognize this early, and I'll tell you why. Patients often have low back pain 6 weeks before we discover they have spinal cord compression. And if we don't catch this early, the patient is going to have permanent neurological deficits, okay, on top of having cancer. And we don't want to do that to people, okay? So it can occur due to bone metastasis from a certain type of cancer or metastasis to the spinal cord, okay? So it can either be bone mets or mets to the spinal cord. The patient's going to present with low back pain, and I mentioned they could have that pain for up to 6 weeks before you discover other deficits. So they could have a change in bowel or bladder habits, like somebody with cancer all of a sudden gets incontinent, or they have bladder retention. They can't void. Either of those things, you got to investigate and let somebody know, report it to the provider, because it could mean they're developing spinal cord compression. They could have changes in sensation, like somebody that has never had numbness in their lower extremities could now state they can't feel their feet. So early treatment is paramount to prevent neurological damage. Now the treatment is going to be to administer high-dose steroids, radiation, chemo, surgery. They may go for surgery, and they may need braces to help with spinal cord stabilization. The most important health education in healthcare to prevent is that as a nurse you engage in health promotion and disease prevention. And I talked about all those strategies earlier in this lecture, because we should be trying to prevent cancer, not waiting until it's discovered late in the course of the cancer. Okay, screening, like the diagnostic testing in self-exams, especially breast self-exam and testicular self-exams for men. In early diagnosis, because the earlier cancer is caught, the better off the treatment is going to work, or the better off the patient will be. A mnemonic that you can teach your patient is called caution, okay? And this is to detect cancer, so when you're doing your patient teaching. So C stands for a change in bowel or bladder habits. A sore that does not heal, okay? Unusual bleeding or discharge. Especially like postmenopausal women, if they start having vaginal bleeding, that is not a good sign. It's probably a sign of cancer, and discharge as well. T is for thickening or a lump in the breast or elsewhere. I is for indigestion. I had talked earlier about GERD causing cancer. Also, O is for obvious change in a wart, in a mole. You should be looking at your moles and have them inspected once a year to make sure there's no changes in them. And then N is for a nagging cough or hoarseness that does not get better. And N is also for night sweats, which can be a symptom of lymphomas or certain kinds of cancers. Patients may undergo a procedure called a biopsy, and there's different kinds of biopsies, okay? And we'll go over a little bit briefly about them. But you need to witness the informed consent because it is an invasive procedure. Ensure your patient has stopped all those medications such as aspirin, Coumadin, which is warfarin, any anticoagulants, okay? Herbals, remember all the G's like garlic, ginger, golden seal, ginseng. You want to make sure they've stopped taking their herbal medications. Now, a shave biopsy is to detect skin cancer, and it's exactly what it sounds like. They shave a bit of the skin where it looks like cancer off, and they send it off to the pathology lab to read it. A needle biopsy removes either tissue, fluid, or bone marrow. Okay, and so that's invasive. Bone marrow aspiration can be quite painful, so you'll pre-medicate your patient. A sentinel node biopsy is when dye is injected and the cells with cancer will take up the dye, I guess I should say. So it lets the surgeon know, like a lot of times they did it when I worked in PACU, I would get like a mastectomy patient with a sentinel node biopsy. And they would see how many sentinel nodes they had that would like point to the spread of the disease. And then an incisional biopsy is part of the cell or part of something is removed. Excisional is all of the tumor is removed. And like for the skin, it would be like a punch biopsy if a mole is removed. So that's just like different kinds of biopsies. Okay, a biopsy is a procedure, so you are going to need to witness the informed consent. Okay, you need to ensure that meds and herbal medications were held. Remember, just like with surgery, you want to make sure they held the aspirin, ibuprofen or Advil, also like warfarin, any anticoagulants. You want to make sure herbal medications have been held before the biopsy because remember those G herbs can cause bleeding like ginkgo, ginger, garlic, okay? So those kind of herbal medications need to go in the medication reconciliation administration record, your MAR, right? A shave biopsy means they shave a little skin. It's typically done for skin cancer. It's just like it says. They shave off the area where they think there's cancer. A needle biopsy means they remove tissue, fluid, or bone marrow. A sentinel node biopsy is typically done after like a breast mastectomy. And dye is injected so the surgeon can see where the sentinel nodes are and determine how far like the cancer has spread. And then an incisional biopsy is part of a tumor or growth has been removed. And excisional means all of the tumor or growth has been removed. An example of an excisional would be a punch biopsy where they excise like a mole. Okay. There's many types of treatment for cancer. For example, the tumor could be removed, like the whole tumor, an excisional removal. Lymph node dissection could happen around the area of the tumor. They can do prophylactic surgery, for example, like somebody who has the BRCA genes may be at risk for breast cancer, and they could prophylactically, which means as a preventative measure, do a double mastectomy. Chemotherapy is an option, radiation is an option, hormone therapy, and immunotherapy. I'm going to talk about chemotherapy and radiation, and I'll let your pharmacology teacher talk about hormone therapy and immunotherapy. So chemotherapy is a form of cancer treatment, and it can either cure cancer, control its progression, or it can be given for palliative reasons. And palliative reasons mean, although it's not going to cure you, you may suffer the side effects of chemotherapy for a short period of time, but it may help to make you feel better in the long run. Okay? Chemotherapy is chemicals or drugs, I should say, that are given to break up the cancer cells. So it causes the cells to become cytotic, which means the rapidly growing cells in your body are also going to be affected with chemotherapy. And this is the mucous membranes. So patients can get awful stomatitis. Okay. And you need to know the interventions for that. Hair follicles. So they could suffer from alopecia, which is balding, and bone marrow, which can cause bone marrow suppression. So that means a low white count, a low red blood cell count, and low platelets. And we're going to get into that because those are super important for you to know the nursing interventions for. Usually chemotherapy is, IV therapy is delivered through a vascular access device such as a central line or a portacath, and you'll be learning more about that in IV therapy. Chemotherapy can also be given PO or it could be also topical. Only an oncology certified RN administers really toxic chemotherapy. Even when I worked oncology, we were only allowed to give certain chemotherapy agents, and we had to like double glove and wear glasses and use full PPE when we were giving chemotherapy. Patients who are undergoing chemotherapy can run into complications such as immunosuppressant, because what happens is after a certain amount of time, usually like 2 weeks, say, just as a general rule, the bone marrow is going to be suppressed in the body. So the body is not going to be making white blood cells, red blood cells, and platelets. So first I'm going to talk about neutropenia, which is a decrease in the white blood cells. So if the white blood cell lab value goes less than 2,000, or the absolute neutropenia count is less than 1,000, the patient has neutropenia. Now the problem with neutropenia is it's going to put the patient at risk for infection, but the patient may not present with the normal signs of infection that we're used to. For example, the patient may not even produce a fever. So that means that you need to report any fever of 100 degrees Fahrenheit or 37.8 degrees Celsius or higher, because that could indicate the patient has an infection. You're going to check mucous membranes for signs and symptoms of infection and breakdown. When I worked in oncology, several times a day, we took a flashlight and looked in our patient's mouth. We were looking for mouth sores. We were looking for signs of infection, like fungal infection with white patches. And you always want to, as a general rule, no matter what reason you're taking the cultures, you want to obtain cultures before giving antibiotics. All right, for patients that are neutropenic, which means their WBC is less than 2,000, you want to monitor the temp, the WBC, and the ANC. Now, the ANC is a calculation that the lab does. It's not like a separate blood test, and we don't need to go into what the calculation is, okay? Report persistent cough, any foul-smelling drainage, anything you think could mean an infection, like somebody has blood sugars you can't lower, okay? That could be a sign of an infection, even if they don't have diabetes, okay? They may not even have purulent drainage or fever when there's infection. That's why you have to look for subtle signs of infection. The patient needs to be in a private room, and don't let sick people visit. Probably you might want to limit children because you know how they're germ factories. Patient, if they need to go out of the room, they need to wear a mask to travel. And that's to protect them. They're on protective isolation or protective precautions, neutropenic precautions we used to call them. You want to avoid invasive procedures. No plants in the room because they can harbor bacteria. You want to change any stagnant water in the equipment daily. And then no drinks that are standing out longer than an hour. You have to throw them away, okay? Administer medications to stimulate the WBC. I'll let you learn that in pharmacology. And make sure there's dedicated equipment in the room. And what that means is the stethoscope, anything you need to examine the patient or take care of that patient is in that room stays in that room. You're going to clean it after, but you're not going to take that equipment to another room and then come back to the patient's room. Okay, so dedicated equipment in the room. The food must be cooked, well done. It must be canned or cooked foods only. So like no fresh fruit, no fresh salad. Okay, everything's got to be cooked. And I told you to throw out drinks that are sitting longer than an hour. The patient teaching involved with patients with neutropenia include tell them to avoid crowds and sick people. They need to take their temperature daily and report if it's greater than 100. Avoid yard work, gardening, and changing cat litter because those things for somebody immunosuppressed, they can get infections that way. Wash dishes in hot soapy water. Wash glasses after each use. So you can't have multiple drinks hanging around and they can't be out for longer than an hour, the drinks, right? Wash toothbrush daily in the dishwasher or rinse in a bleach solution. The most typical kind of bleach solution is 10 parts water, 1 part bleach. Don't share personal items. You have to explain to them they can't share towels, toothbrushes, brushes, any kind of personal item. They cannot share it with family members. Let's talk about anemia, which is a reduction in the red blood cell mass. So anemia always puts like an increased workload on the heart and lungs. So people with anemia can develop fatigue. They can get very pale. They can be dizzy. They can have shortness of breath or dyspnea on exertion, which is DOE. So you're going to check their hemoglobins. In a female, normal hemoglobin is 12 to 16, and a male is 14 to 18. So you want to explain to patients they should alternate periods of rest with activity. In other words, they're going to have to do a little activity and then take a rest. Okay? So they can't get everything done in the morning, so to speak. They have to take more rest. You're going to administer epoetin, which is a drug that can increase the red blood cell mass, and ferrous sulfate, which is iron, as ordered. Monitor the hemoglobin values to determine response to the medication, and blood products as ordered. We'll talk about some of these things later in the semester, but the nursing interventions are really important. So thrombocytopenia is also a symptom of bone marrow suppression. Now, the normal value for platelet level is 150,000 to 350,000. So platelets lower than 50,000 causes the patient to be at a risk of injury due to bleeding. Okay, they can bleed out from this. So you have to know how to look for the signs and symptoms. So monitor for petechiae. Petechiae are the pinpoint little it almost looks like a rash on their body. It could look like a rash. So petechiae are small and pinpoint, and it indicates the patient may be bleeding. Ecchymosis is bruising, bleeding gums, and you're going to look for nosebleeds. Do not overinflate the BP cuff because the patient is at risk for bleeding if you do. You want to make sure you're using a lift sheet when you're turning and repositioning the patient. You never want to put your elbow, your arm under their axilla and move them up that way because you can shear the skin that way and they could bleed. You want to minimize needle sticks, injections, laboratory specimens, and intravenous line starts. Use smaller gauge needles and apply pressure for 10 minutes until the bleeding stops. Test all urine and stool for blood. Measure abdominal girth daily to check for internal bleeding, and apply ice to any injured area. With somebody that has thrombocytopenia and they're at risk for bleeding, you do not want them to get constipated because that can cause bleeding from the rectum. So you're going to administer stool softeners. You're not going to take rectal temperatures. You're going to monitor for, I told you, petechiae, ecchymosis, and bleeding of the gums. Administer thrombopoietic medication. You'll learn about that in pharmacology. Remove tripping hazards. In other words, initiate fall precautions. You do not want a patient with thrombocytopenia to fall because they're going to bleed. They could bleed out, okay? You're going to encourage the use of an electric razor. They need to use a soft toothbrush. They need to have good fit with dentures so that their gums don't start bleeding because it could be hard to get them to stop. They shouldn't cough vigorously, blow their nose vigorously. They need to just kind of block their nose. It can be frustrating. But you want to prevent them from bleeding. That's why you're going to initiate these interventions. Then with alopecia, this can occur due to either radiation or chemotherapy. Now, if it's due to chemotherapy, the hair loss is usually only temporary. Sometimes with the radiation, though, if they have radiation to the head, like say they have a brain tumor, it could cause permanent hair loss. The patient teaching, you may ask patients, not encourage, if they would like to cut their hair short before they start chemotherapy. The hair regrowth begins about 1 month after chemo ends, and the new hair, you have to warn them, will be a different texture and color from the original hair. So before they have hair loss, they may need to decide if they're going to wear wigs or have a head cover until the hair is regrown. It's a personal issue with the patient. Whatever they want, we support. Okay, stomatitis and mucositis are side effects of chemotherapy, and it's super important you know how to identify this, but also care for the patient with stomatitis or mucositis. Mucositis refers to irritation throughout the GI tract, whereas stomatitis refers to irritation of the mouth due to chemotherapy. So we used to check the mouth frequently with our flashlights when I worked on oncology, a couple times a shift. And I would call the provider if I saw any mouth sores, if I saw any indication of infection, such as like white patches, anything like that, and the chemotherapy would be stopped. Okay? You're going to encourage consistent oral hygiene before and after meals. That means rinsing the mouth with normal saline at room temperature before and after meals. Super important not to use extremes in temperatures when we're talking about the mouth, okay? So patients should use a soft toothbrush or tooth sponges. It's quite painful. Their mouth is quite painful. You're going to irrigate the mouth because you want to remove any debris in there and counteract acidity, because you don't want acidity is going to make the mouth feel worse if they have stomatitis. I told you, room temperature fluid and foods. Increase the fluid intake to 2 mLs per day to keep the mucous membranes moist. Relieve mouth pain with special topical compounds. So we should have patients like swish and spit, like xylocaine, a viscous form of it. Xylocaine is like a numbing medication. Avoid spicy or salty foods, alcohol, and tobacco. And remember, like, a lot of mouthwashes have alcohol in them. And I don't know if you've ever seen like those lemon glycerin swabs. Don't use those to clean their mouth. Glycerin is a type of alcohol, okay? No tobacco products. You want them to eat, encourage food that's bland and high in calories, like mashed potatoes. You may have to start adding like protein powder and encouraging protein drinks. You don't want them to drink fluid during their meal because you don't want them to get too full easily, okay? Because if they have stomatitis, they may become malnourished because it's very uncomfortable to eat. Okay, nausea, vomiting, and anorexia can happen with cancer treatment as well. And we take a multimodal approach to combating nausea, vomiting, and anorexia. So first of all, this is why in clinical we don't want you using heavy scents like perfume or wearing smelly lotions, because patients that are nauseous or suffer from nausea do not like the smell of heavy scents. It can set them off. You want to make sure you keep the environment neat and clean. So like channel your inner Florence Nightingale and make sure the environment is pleasant, right? And you don't keep like your urinals on the bedside table. That drives me crazy when I walk in a room and I see a meal and 3 full urinals on the bedside table. Patients are not going to like that smell, and it's going to make them not want to eat because they'll get nauseous. And then mouth care before eating is a good intervention to make them feel better and encourage them to eat. I talked about protein shakes and powder. Several small meals a day are better than 3 meals a day. You want the food, you don't want the food with extreme temperatures, too hot or too cold, but cold food is better if they don't feel like eating. And then avoid drinking during meals. Some other side effects of chemotherapy include chemo-induced neuropathy. I don't know if you've had neuropathy before in fundamentals, but neuropathy is when like the nerves in the become damaged. So the patient could complain about numbness and tingling in their extremities, like in their hands or their feet. They could develop constipation because the movement of the bowel depends on the nerves to make it move, so they could get constipated. They could have orthostatic hypotension. You want to prevent injury. For example, if a patient has numbness of their feet or their hands, they may not feel like extremes in temperature, so you have to make sure the bath water is the appropriate temperature. They need to inspect their feet daily because they may not notice that they cut their foot or something like that. So you have to teach them that. Cognitive impairment refers to, I don't know if you've ever heard the term chemo fog or chemo brain. So it could only affect it during the chemotherapy, but it could also have lasting effects. So you want to encourage them to engage in strategies that boost cognitive function, like doing puzzles or reading books, etc. Okay, we're going to talk about radiation now, which is another treatment for cancer. And it can be used in combination with drugs, like hormones, etc., and also with chemotherapy. There's two basic types of radiation therapy, and you have to understand the difference between them and the interventions for each one, okay? So brachytherapy is the first type. The word brachy means short. So it's shorter treatment. It's internal treatment. Like it could be giving an IV that's radioactive. It could be giving PO medications that are radioactive. And next semester, when you have thyroid disease, I talk about this, okay, getting brachytherapy for thyroid cancer. And then it could also mean, like, for example, an implant, like a vaginal implant for cervical cancer. Okay, that can be just some examples. Tele means distant, okay, or far. So teletherapy, it refers to external radiation. So the patient is not radioactive, but they receive radiation through an external radiation beam. Okay, radiation is destroys malignant cells. That's why they use it, and there's no permanent damage to the adjacent body tissue. Okay, so unlike chemotherapy, it doesn't damage other cells. It can be very targeted to just cancer, and the course of radiation is spread over a couple of days to weeks. So with brachytherapy, it could be a couple of days, and then with teletherapy, it could be over a period of weeks. Okay, brachytherapy is internal radiation treatment. Now, when a patient is having brachytherapy, all their waste products, urine, feces, and meces, are radioactive. So wherever you work, there's going to be a policy about waste products. Now, when I worked in oncology and I took care of brachytherapy patients, I'm just going to give you an example. If they urinated, I would put the urine in the toilet and flush it twice. That's what our protocol was at that time. You place the patient in a private room, limit visitors to 30 minutes per day, keep the door closed. Okay? You want to place a sign on the door warning of radiation because you do not want pregnant people going in there or children going in there. You're going to wear a dosimeter, which is a film badge that records the personal amount of radiation you are experiencing. You've probably seen x-ray technicians wearing these. Okay, so you will have one that is delegated to you if you work in an area with brachytherapy. You want to maintain 6 feet when possible and visits no longer than 30 minutes. Now, what I would do is stand at the door, which is greater than 6 feet from the bed, and I would ask the patient if they needed anything, or I would use the call bell system to ask if they needed anything. I only went in the room when it was absolutely necessary. You want to restrict pregnant visitors. people trying to become pregnant, and children 16 and under. You never remove items from the room. For example, if I had to change the linens on a bed, those items stayed in the room. If I had to, say the patient ate, then the tray would go in a certain place, but it would not be removed from the room. And if the implant became dislodged, you pick it up with forceps and place it in a lead container. You wear an apron. The back of the apron, so you're protected on the front of your body. So you never want your back facing the patient. You always want the lead apron where the lead apron is facing, so the patient. All right, with teletherapy, remember this is external beam radiation. The skin is marked with tattoos that guide the positioning of the radiation. So tell the patient not to remove or wash off tattoos. Provide well-balanced meals, no red meat, because radiation can cause something called dysgeuria, which means altered taste. It means they feel like red meat tastes like tin, okay? Monitor for fatigue. Radiation makes people super tired. And monitor for injury to skin from the radiation. Now, patients can get radiation in different areas of the body. So, with the skin, you're looking for blanching, redness, desquamation, which means sloughing off of the skin, and hemorrhage. So anybody getting radiation through the skin needs to stay out of the sun, okay? That's one of the things you're going to do. Also, you can't massage the skin or use washcloths. You have to tell them to use a hand when they're taking their own hand with soap when they're taking a shower, because you don't want to irritate the skin, and they need to wear soft clothing. If they have a radiation of the head and neck, they may develop mucositis, which I've already talked about. So it is, if they get stomatitis or mucositis, they will follow those same interventions we talked about earlier. Xerostomia is dry mouth, okay? So you would use lubricating, lip balm, for them, and then ulcerations inside the mouth. So be looking for that. If they're having neck radiation, they may have difficulty swallowing, so dysphagia. They may have, in their abdomen, gastroenteritis. So encourage a low fiber foods that slow down the GI tract, because they could get diarrhea. Monitor their complete blood count for decreased platelets and white blood cells, because radiation therapy can also cause some bone marrow suppression. Instruct the patient to avoid hot, spicy foods. You want to avoid hot, spicy, salty, the same interventions as stomatitis. Don't use lotion, harsh soap, powder, ointments, or perfumes on skin that's been treated with radiation. If you have any questions, you can bring them to tutoring. You can email your instructor. You can write them down and ask before class starts. You can use the Ask Instructor feature in Blackboard. We are here to support you, so let us know if you need any help. Cancer is staged and graded, and I don't want you to spend a lot of time trying to memorize this system, okay? If patients have higher numbers, that means the cancer is more advanced. So that's basically what you need to know about this whole staging system.